your provider logs in, they'll take of who their job actually is. This is the anesthesiology module, which is the same for anesthesiologist or CRNAs. It's roughly always the same. There's really not that big of a difference. Some of it comes with just different permissions. But once we log in, you'll log into whatever department at that particular hospital. So this one is going to look essentially almost exactly like if you were to do a rotation at Missouri Baptist for some reason. But again, all the components are relatively the same. So yes, we know this is the playground, so there won't be any real patients' names. And for this month, they made all of the patients' names dog breeds for some reason. It's just kind of weird. This is something, again, you won't have to do. This is really just trying to say, hey, how do you want your epic to look? And we're going to say, all right, so when you first log in or your provider logs in for you, essentially you're going to see what we call the board. If you were to walk in an OR and look on the wall and you're in the main office, there'd be a large board with all the cases on there, who would be the providers and things like that. So this is essentially what the board essentially looks like. If you look here at the top ribbon, which is right here across the top, you see something called My Cases. If you were to click that, it's only going to give you cases that you were actually assigned. So notice that I'm not assigned to any of those cases. So the actual board is going to be the one that says OR cases. Now, if you were to go off to the GI center for some reason, then there would be GI cases. So this would be the GI board, which there aren't any there. If you were to go to the cath lab, you would go to the cath labs board. These are the NORA, non-OR anesthetics. So if you were to go to places like anywhere that was giving anesthesia, hell, it could be the ER, even though there's radiology cases. If you were to do like a bronchoscopy in the bronchoscopy lab or some kind of intervention, then you could click on those reports as well. A lot of times they will also put OB usually somewhere, although OB, you notice there's this ribbon and then there's a ribbon on top, one of which is the status board. This little one is labor and deliveries, kind of their version of their kind of board that has all of the patients in their unit, including any of them. Something you guys don't have to worry about now. The other ones, you'll see patient lists. So if you were to look for a patient in the particular hospital, this would be like kind of like your little seek and find. You can also, you can also look in different ways, but this is probably the easiest. So you'd have to choose the hospital that you're at in the system. You'd have to click units, and then you'd have to find out where they are in that particular unit. I'll show you how to search in particular, but like if, for example, if they were in what we call our PCU, they'd show a list of patients and which rooms they're actually in. So that's one way. You'll notice here, this is for the provider dashboard, something you will not have to worry about. Same goes for the Guardian. And same goes for secure chat. So really your big thing is being able to find your OR cases and find your patient. Sometimes you will also see that providers are also assigned to these rooms. So you'll see providers' names assigned to each one of these. So this is training room 2, this is the same room. So they put all these cases in essentially one room. You'll notice that there's a time, that's the scheduled time. You'll notice that the procedure is listed out. So this one's a laparoscopic surgical repair initial. You'll see the surgeon's name, Dr. Timely, MD. You'll see the patient's name. You'll see the patient's birth date. And you'll see, just like I've told you before, what the scheduled anesthetic is. In this case, it's general. Off to the right, you'll notice there's a bunch of symbols, as well as there's symbols onto the left. And if you notice that at the bottom, the colors will let you know what's going on with that particular square or procedure. So notice all of them are yellow, which means they are all in the pre-procedure area. In other words, they're all in pre-op. Notice that a bunch of them have purple crosses that are off to the left here. If you click this legend here, you'll actually get a legend of everything, what those little markers may actually mean. So if we move these are all add-ons. The case with the purple, it's a scheduled add-on. You'll see the anesthesia type. It can be general, MAC, epidural, regional, spinal, local, and so that would be in that little area that's right up here. The events, which is this part over to the right side, you'll see that there is a pre-procedure complete. It'll tell you whether they're in the facility. It also tells you, like, when you're doing stuff in the room and you click a certain event, it will post that up to the OR board. So people may know that incision has been made, or intubation has been done, or patient's been extubated, or induction, or anesthesia start. Typically the one seen is anesthesia start for most of these type of things. Let's see, they might be, let's see, using this. Tell you what, we're going to try to do. Let's find one that hasn't been used if someone's done all these pre-procedures. So we're going to log out for a sec because I have more than one username. And it says, yep, not me. So we're going to do the opposite. E, and let's do 15. Let's see if that works or not. Let's try a different one here. One. There we go. Let's see if they've got some open ones on this one. Just making sure I'm not interrupting some class that they're doing across the way here. Yep. Right. There we go. We got some open ones there. Okay, perfect. Okay, so the system is divided so that once you click on someone's name, you're going to start. However, if you just wanted to see quickly about the patient, like for example, this patient here, knows how it highlights it in orange. It all of a sudden starts highlighting different phases of anesthesia or things that you can do with this patient. So right now, I'm not in that patient's chart until I click one of these types of things. One of the things that I could do is, let's see if it has a pre-review. If I just wanted to take a quick glance without starting anything on the patients, I click this pre-review, and what it does is just give me a quick little, like, everything that's in the chart I can see. So for example, this patient is scheduled for laparoscopic inguinal hernia repair. Looks like umbilical hernia repair as well. It looks like pre-procedure vitals. You're looking for the height and weight, whether they've been a smoker, what their allergies are. So this one has egg yolk, penicillins, and strawberries. Fantastic. It also shows their home medications. So if you think about all the things that are on your pre-operative evaluation, you're seeing a lot of the easy free ones right here. These are things that are already in the system that someone has already filled out, including things like the labs. So you can kind of take a quick glance at it if you want to. If you wanted to kind of look into their chart without actually opening an anesthesia record, once you double click on one of these or you open the chart, it creates a log for that particular procedure, and it pretty much gets everything ready to go as far as, hey, anesthesia is going to look at this patient. If you just wanted to look at the patients, like open their chart, just kind of glance around, you'd use this button, which is the chart review. And chart review has just about everything. So we're going to click chart review. You'll notice that there is a ribbon to the side, and then there are tabs to the top. You'll notice that there's the chart review, and if under the tabs there, you can look at previous anesthetics if they've had one. Looks like today that they've kind of filled out one. Previous surgeries that they've had, so previous surgeries at this facility, not necessarily all things, but those that have already been in the system. You can look at all the notes, which is there's a note tab up here, there's a note tab up here. This note down here, since this is in the chart review, is every note ever if they've ever been at this hospital, not just today's or this encounter, which is like this admission. It's for all of them. If you click on the notes up here, it's for this admission, essentially. You can click on labs, and this kind of gives you just a list of labs, and it will, you have to double click them to see the results, but we're going to use results review here in a second to review the labs. You can look at imaging. if there was an X-ray, EKGs if they were in there, previous procedures, all different kinds of medications, media, which could be things like things that have been scanned and uploaded to Epic. Same thing for like letters. These are things from doctors' offices and referrals and all those different things. You can even look at what they have. Usually there's not much in the summation extracts. So that's just literally just looking at the chart. You can also click the summary button, and it likes to bring up if there was an anesthesia record, which let's see if they have one going. This shows that there's an open record currently. It's not showing much here because they probably haven't started a case in this one. This is showing the actual record, intraoperative record, because it sees intra-procedure grid and graph, labs, all these different, these are just, again, just different things to look at. But again, right now we're in chart review. We're just kind of looking at the patient. Here's what notes would be for this particular admission. Notice that right now for this admission, there's only 2 notes. So there's a note from one of the nurses, there's a note from our surgeon, no changes to the H&P. You click on load all notes, then we start to see an actual H&P. This is H&P view only. If you see view only, that means that it's probably in process of being made. This one has been signed. So we're going to just quickly look at this one here. If we look off to the right, this is the actual H&P. We're going to expand all so you can see everything. It's showing the past surgical history, family history. Again, this is not what you filled out. This is what someone else has already filled out. And you'll notice that with Epic, there's a lot of canned stuff, which means it's stuff that's pre-made. It's not like someone sat down and typed all this stuff off. This is a lot of pre-filled stuff, just like our stuff will be. But it does show things like the allergies, stuff that we already knew. Here's the surgeon's physical exam and assessment and the surgeon's actual plan. When looking at the informed consent, looking at the surgeon's H&P and looking down at the plan, those two should match. That's where the that's where the informed consent should be based off of. And so the diagnosis is for this particular patient happens to be left inguinal hernia, which is reducible, along with an umbilical hernia. And when we go to the bottom plan, discuss the possibilities. And let's see, patient selected to have procedure surgical treatment, strangulation time, face, discuss the risk, incisional, complex. And what this one should do, patient understands, is that this should actually say plan should be a inguinal hernia repair, left inguinal hernia repair with umbilical hernia repair. So whoever mocked this up did a really bad job of being a doctor. Let's see if it actually says it on this one here. Nope, not on there. Okay. So the other thing that you may be or may or not, more likely may not responsible are our orders, but we're going to get that to the orders under our, when we actually open the chart as an anesthesia record. So notice that this patient, you can have more than one patient open in these tabs. So be aware that you don't want to be charting on the wrong patient if you have more than one patient open. If you look over here to the left, normally their picture should be up here. Their name should be up here. You'll see all of their information. Usually when you hover, let's see if it lets you do it. Yep. Nope. Not that. I'll go back to chart review. If you hover, it'll bring up a little window off to the side. So you can see everything from medical record number to their contacts, age, birthday. In each one of these boxes, you should almost be able to hover over. For example, if we hover over allergies, and you see egg yolk, penicillins, and strawberry, it'll tell you the severity and what happens with each one of those. So technically, when we look at this, for example, you'd like, oh, egg yolk, oh my God, they can't have propofol. Well, their stomach gets upset. That's not really an allergy. The hives with the penicillin, probably strawberry and itching. We're not going to give them any strawberries. So also when you click over here, when you are not click, but you just hover over, Not only will you see over here the quick little heights, weights, it even gave you your ideal body weight so you didn't have to calculate, or your BMI. But when you hover, it gives you all these other things. And more importantly, if you look there at the bottom, you'll see that there is an adjusted body weight with the ideal body weight for things like calculating drugs, gives you body surface areas, and all the basic values that are on there as well. Um, Also, along this ribbon that's technically on the left, you'll see what the procedure is. These are all customizable fields, so each hospital is going to have different stuff over here on the left. Things from labs to medical history. Makes it pretty convenient to see those kind of things. If you look over here on the right, you'll see that there is an orders section here. Again, we're going to talk about orders and the way that an anesthesia record would actually, how it would be done. And if you also look down here at the very bottom, not every hospital does this, but some of them try to look for the things that you need to make sure that are done before going back for surgery. So there should be an H&P. Is there surgical consent? Is there advanced directives, living wills, things like that? So those are things that are going to be on there as well. So we're going to close this patient because this is just if we wanted to review. Okay. And as we go back to the board, okay, you'll also notice that we can choose any patient, and we can also choose the preoperative part of the record, the intraoperative part of the record, the postoperative part of the record, or the orders for that particular patient. Or we can actually open the chart. And so the way that the system is really designed is not really to click each individual one of these, but to start off with one of these patients. So we're going to click one that, let's see if they've had all their stuff done. Let's see if those are all pre-procedure complete. We're going to click on one of these that technically white means that they're not in the hospital. There are places, just so that you know, you're probably wondering what this PAT is. That's pre-anesthetic testing. So a lot of patients come in days before to have their preoperative stuff done, which case you would go through the preoperative testing to fill out all this information rather than start an intraoperative record that isn't going to start for 3 or 4 days. So we're going to go and we're going to double click this patient here, Deshaun. And so notice that now that I have, this is essentially creating a log. In other words, I have started kind of an anesthetic at this point. Notice that there are tabs in this upper ribbon here: intra-procedure, pre-procedure, post-procedure. This one's a great one for inpatients when you click the avatar. And so when you click the avatar, it brings up the person and it will actually list all your lines, drains, and airways. And so it will put a picture, it will list all of the numbers that are on there and tell you where. So you, without having to go up 4 floors to find out what kind of lines they have so that you know how to set up the room, you can actually go to the patient's avatar, see which lines they have in, see which wounds they have, things like that, and plan accordingly, which is kind of a nice thing. So we're going to go back to pre-procedure because that's the first thing we'd want to do. Also, I guess we'll kind of, before we get into that, we'll hit this results review. So anytime you're in any patient's chart, when you're in the chart review, notice that I can hit chart review just like we did before. And if I wanted to look at the labs, right, in which there aren't any labs here, of course, but if I want to look at labs, it would just show each individual lab as like almost an order. But if I'm in the results review section, and I say I want all data, hit accept, they probably don't have any data, so we'll have to find. What you'd see is you'd see all the different areas like hematology, coagulation, things like that, chemistry, and you'd click them and you'd be able to see not only all of the labs, but all of the history of their labs. So you'd be able to see it. We'll find one towards the end here. We'll see someone who had some labs. I think that first one kind of did. We'll be able to go back in there. So we're going to go back to our pre-procedure. So these are set up so that you can kind of go through them in order. You'll notice that we are in the pre-procedure area. The inter-procedure would be like the anesthesia record. The post-procedure would be just like the pre. You'll also notice it's listed here as pre-procedure. You'll also see that these things on the left correspond to the titles that are up here. So see, best practices here goes with this one. Procedure info is procedure info here. So these are like shortcuts to get there, and it brings these essentially to the top. And so as I click each one, I can go through them like this, or if I scroll down, I can see, for example, if I scroll down this way, all the way to like OBGN status is here, then it goes problem list. So this all goes in order. And so the best way to kind of do this is just to really just kind of click through this list and then deal with the thing that's on top at best. So when looking through these subjects, and so the pre-procedure, okay, so it has everything that a preoperative eval plus probably a little bit more, and it has things for you to do. You'll see once we kind of get to the part way down here where it says pre-evaluation, that's where it's going to start to look maybe a little bit more familiar to you as a true preoperative evaluation. After we're done with this whole section, it is going to generate a note, and that note is going to be a anesthetic pre-procedure or pre-evaluation note. That note would be the same thing as you writing on the back of the anesthesia record where all the preoperative eval stuff is. Okay, so you'll notice that as we go through these, not all of them are always applicable to anesthesia, but just go through them because they're there so that they can bring any information that you may want to know. So as we go from top to bottom, we click best practice, and there are no best practice advisories. If there is just a close, you don't have to click it to confirm it, okay? You can just go on to the next section. You can go on to the next section by clicking here. You can go to the next section by clicking here. And notice when I go to procedure info, you see procedure info is highlighted over here on the left. So notice that, again, this is not something that you have to confirm. This is just literally just for you to look at. This is showing you, hey, this is the procedure. This is the anesthesia type that was asked for or scheduled. Shows you what their preoperative diagnosis is, and it shows them kind of where they're at right now. Tells you who the surgeon was, the time, and the case number. Again, you don't have to hit close. You don't really have to hit more information, and there's nothing for you to confirm. This is, again, just for you to go through. Would they be able to tell if you didn't look at this section? No, they wouldn't also be able to tell if you didn't look at that section. So we're going to go to the next section, which is attached procedures. So this needs to make sure that the procedure, that something needs to be attaching this anesthesia record to some procedure. So there may be a whole list of things, of procedures. It could be MRI. It could be a CT. It could be bronchoscopy. You want this to be for the surgery that you're going to provide anesthesia for. So it's saying, hey, in the OR, there's a laparoscopic surgery, inguinal hernia, and we want to attach the anesthesia record that we're filling out, and we want to link it to this procedure. Okay. Again, there's nothing for you to confirm or anything else. There is a checkbox. So you could uncheck it, but it says, hey, you need to actually, assign a case to it. And again, once it's done, we can move on to the next section by either going to next or hitting that button, or we can even be clicking that one. So we're going to click previous anesthetic records. It looks through the entire Epic system that it can, and if it's linked to the Epic Worldwide, which is kind of all the hospitals, if they've been released or they were allowed to be able to look at, you'd be able to look at previous anesthetic records. There are no previous anesthetic records for this particular patient. It doesn't necessarily mean they've never had surgery or anesthesia at that facility. It just means since the inception of their of Epic, they haven't had a surgery. They may have paper records that are down in medical records, but Epic will not be able to pull those. Obviously, notice it just says close or previous or next. There's nothing here for you to confirm to move on to the next section. Vitals. So these are the preoperative vitals, the true preoperative vitals. And so if you look from the top, you could, if you wanted to, if you were the first one to see this patient and it was right now, you could start putting in some vital signs if you wanted to show. As we scroll down, notice that you can put their temp, what was the source, pulse, respiratory, all these things. It doesn't mean you have to fill everything out, just what you kind of had. Now, as we move down and I kind of go towards the bottom of this section here, let's go down and PO, all those fun things. Yeah, lots of stuff that really aren't, hopefully you're probably not going to be filling out per se. Let me go, oops, sorry. Vitals, vitals, vitals. That should be something at the end here that we'd be able to see. There we go. If we close on this one, it will show you like you guys used to see on your flow sheets. So really what it had before was if you had a new reading, it would bring all these things up, uh, which we don't have. So we want to see what the nurse took. Maybe the nurse has already been there and it took them. So then we can click close and it will show you that at 4:18 in the morning on January 18th, 2021, that they had blood pressure taken. So obviously, if they were here this morning, you would see the more recent ones. It shows you the last filed and it shows you a history. So you could actually go through all this. Again, this is all still in the vitals section. There is nothing for you to confirm or prove that you've seen it because your anesthesia note will pull this information into it. Next section is OB-GYN, GYN status. Again, this is usually stuff that nurses have asked before you've gotten to them, but you can certainly ask if the nurse has not gotten to them. Now, this is the actual first section where you see a button that says Mark as Reviewed. Mark as Reviewed is something you should probably click because it shows and gives you a timestamp that says, hey, at this particular time, I knew this much. And so currently pregnant, no, or if they were breastfeeding, all these other different things. And so when we click on it, right, we're going to click Mark as Reviewed. It says, hey, anesthesiologist Alexa Annie Agia reviewed this at 3/1/21 at 4 o'clock p.m. Okay. Now that you've done that, you've marked and you reviewed it, you can now move on to the next section. The next section is the problem list. This is not necessarily for anesthesia people to fill out. This is usually what all the hospitalists and everything else. Essentially, you're going to just review this. We don't normally add new problems as anesthesia providers, even if you think they have, let's say, hypertension. But if they're not physically diagnosed with it, okay, we're not going to put it on the hospital's problem list. You're not going to make that type of diagnosis. You can certainly put it on your anesthesia preoperative evaluation, but this is the problem list that travels with the patient throughout the hospital. So just imagine you say they have hypertension, and then someone comes around and says, well, who put this down? They don't have high blood pressure. Where's the diagnosis at? They find out that you did it. That's probably not what you want. So we're going to review this, and we're going to, again, we have another Mark as Reviewed button. We're going to click that, okay? We're going to move on to the next section. You kind of notice that things that are kind of important usually have a Mark as Reviewed. And so we see the patient's allergic to egg yolk, stomach upset, penicillins. You can certainly change what's in here or add to there. Has an unable to assess, like if they're unconscious or trauma. But again, it has a Mark as Reviewed. So we're going to click Mark as Reviewed because we've reviewed these allergies. We're then going to go to medication review. These are the medications that are showing more than likely the patient's, this is an outpatient, so this is usually just showing what the patient has listed. A lot of times the nurses have already gone through when they took their albuterol, the time, how often, if they're taking PRN kind of stuff right here. Again, this is for you to look at their medications, look at a list. And so you're going to hit, again, just like you heard before, Mark as Reviewed, okay? And you can certainly ask the patient. So this would be the screen, again, that you would probably want open while you're talking to the patient preoperative. At the preoperative area, so that you can say, hey, I see that you're taking albuterol, and if the nurse hadn't like put it on there, like how often do you really take it? Have you ever taken it ever? Now's a good time to ask about if they're taking insulin, you know, what their blood sugars are like, and other reasons why they're taking different medications. Again, it has the Mark as Reviewed. Make sure you hit that. The next one, history. And it is showing not only just any history, it's showing their surgical history and it's showing their anesthetic history. It also has their social and substance use history. So for example, all of their surgeries should be listed. Notice that they put all, you don't have to put no to every little thing that you see here. So it's chart by exception for most of Epic. They just put very common procedures up here so that if you ran into a surgery, for example, that they had that wasn't listed. So you would ask the patient, say, okay, I see that you've had tonsils and your adenoids taken out. Have you ever had any other surgery? and they go, oh yeah, I've had a hernia repair. Then you click yes. You probably want to click that little note button and say, well, what side did you have your hernia on? Well, he's having his left on, so we already had the right done. How long ago was that done? Oh, it was done 1990. Sure. And what did they put mesh in? Yeah, sure, mesh. And so that would show up on your note when you pull it up later on. We'll talk about that. Anesthetic history, in other words, did you have any problems with anesthesia? Notice that they put a lot of common things like P1V, things like that. It says looks like, and then it also shows other medical history. Oops, let's scroll down. Surgical history, medical history. Let's go down just a little bit. Um, oh, their medical history. It's showing all the different things, which these are the things that were listed as prime health things that were on the problem list. So we're not going to mess with those. You can also see down below if they were smoker, so never smoked. Now they have e-cigarette and vaping now. Is that fun stuff now? There should also be substance use, drug use, things like usually for, I wonder if they put the alcohol on there anymore. They used to. Yeah, so if you click alcohol, right, drug use, yes, alcohol, how many times per week? 5. And you can add a note to that saying, hard liquor or something like that. Again, you're not required to fill out all these things, but if you asked about them, then go ahead and fill it out. You don't have to ask a family history. So these are things that get pulled from the chart. Usually we're not that worried about it unless they have a anesthetic history. And then it may be important to fill some of that out. But for the most part, we're not going to ask about everything. Obstetric history, if they're up in OB or they've recently, or if they are pregnant or recently delivered, it might be good to fill out some of the obstetric history. And again, at the end, mark as reviewed. So we're going to click mark as reviewed, and it showed that we did it. Oh, I guess alcohol has its own section now, I guess. There we go. I guess that used to be in the same section, but now we've got all kinds of fancy alcohol questions. Now notice that we go down here and we click pre-evaluation, and that's really going to be our pre-operative evaluation here. When we do that, it's going to bring up what's called the note writer. You'll notice that off to the right, this is an actual note, and so already it has picked up. And I'm gonna move this over here a little bit, see if we can get that. There we go. Let's move that over, just so that you can see it. So you can see that it's already put the patient's information on there. It's talked about the active problem list, their past medical history, surgical history. So this is all the stuff that we just reviewed and looked through, and it has already pulled it into this one-page note sheet. It's even pulled all of the medications. It's pulled all of the social history. Shows that the alcohol, family history. It pulls all the labs from the patient, which this patient didn't have any labs, right? And this patient should probably, which it's not showing on here, again, it's not going to remember everything, right? This patient should probably have a pregnancy test. So that should be something that should be in the labs that is not for this particular patient. Now notice this note does not have everything. And that's because we haven't really filled everything out. And so we have our note writer, and you'll see that's a lot of busy stuff here. It's still showing all the different, in this particular part of the ribbon, it's still showing all of the stuff that you see that was already pulled in. But this part right here, you'll notice that there's a couple tabs. You'll see that there's the pre-anesthetic testing review of systems. There's the pre-anesthetic testing physical exam. There's the day of surgery physical exam, and then there's the anesthetic plan. So that whole sheet that we used to fill out for the preoperative stuff is divided up into little sections. And so we also need to make sure that we're pulling the right type of patient. So adult versus pediatric, additional info, we're not going to really put that on there. So We're going to do not the PAT physical exam. We're going to do the review of systems. So remember when we look through all the systems, this one has essentially pulled everything, and it also pulls things from the chart that it thinks might be an issue. And so as we kind of go through that, notice how each system has essentially things that you could ask about, but you can always add to it. So, for example, neuropsych. Have you ever had a stroke? Have you ever had carotid endarterectomy or stents, seizures? Psychiatric, we can mark the system as negative, right? Cardiovascular. Let's say that we think that they do have high blood pressure, but they're not being treated. Notice that the diagnosis, you don't have to fill this stuff out, but notice that once I've clicked something positive, it added it, it has added it to my note as just like you would write on your piece of paper, high blood pressure. Notice that it doesn't add it to the active problem list or anything that's going to fall into the hospital. These are just going to be your possible notes, and you have the ability, you could follow what it's asking you, or you could just write a note, a small comment. But this is giving you suggestions. Let's if they've had a heart attack, coronary disease, and if they've had coronary disease or if they've had stents, it's going to ask you all these different things. And so when you click the positive, it shows up there. So notice now I move on to things like respiratory. Notice that there's a warning sign, and that just means that the information is recommended. The patient's problem list or past medical history contains asthma. And so when we look down here at the past medical history, it shows asthma. So it says, hey, you probably want to click asthma, and frequency almost never. I get it when I get sick. No hospitalizations, most recent exacerbation. You don't have to fill this stuff out, but it's just showing you the more stuff that you click, it keeps on adding it to the positive things. Notice that it puts it in red there as well. Okay, so now, and so we can keep on going. So we can say negative for hepatic, no reflux. You could put, let's see, no, doesn't let you put, it does let you put a pertinent negative. So if you click this, that means that if you wanted to show someone that definitely they were not GERD, when I talked to them, I definitely asked, you could say mark system negative, which would count. But if you notice on the right, there's a negative versus the positive that's on the left, you could put a pertinent negative on there if you thought that it was going to be challenged or whatever it was going to be. So we can go through all the review systems. Notice that it gets a little busy. So we like getting rid of this crap over here. Make this a little bit bigger. So we're going to say negative. Let's say relatively healthy. Again, endocrine. So it says yes, they're diabetic. We can say that they're type 2. Outpatient insulin use, none. Do they have any complications? No A1Cs to really know. They don't check their blood sugar at home. We can even put a note here that says diet controlled. No glucose checks. And notice that when I click check off to there, it has added it to my note over on the right. It could go through like the functional capacity, like in other words, are they going in there? Possibility of pregnancy assessed. So ruled out by patient's history, negative C labs. So this is your opportunity to say, yes, I did go look at the labs and the labs were negative. The patient's not pregnant. And also too, here is some of your physical exam. However, day of surgery physical exam is where we're going to see these. So these are some of these different things, everything from asking about different symptoms they may be having. You can have positives or negatives depending on what you see. But essentially, that's the end of that particular section. So the next section that you see up on top here says PAT physical exam. Well, it's the day of surgery, so we don't need to do that one. We're doing the day of surgery physical exam. It's going to ask you to attest to this pre-anesthetic testing, which is today's date. Anything that's in red, you kind of have to fill out, okay? Medications, history, and allergies all reviewed. And then you get into your actual physical exam. So you're looking for what? Here's your airway. And you're not limited to just this, because at the very bottom, I'm just going to scroll down to the bottom here, you can also write extra comments down there below. So you're not limited to these things. So notice it has some check boxes. So Mel Pouty 2, greater than 3.5, full range of motion, full range of motion. They have good mouth opening. We're not worried. Cardiac exam, so regular, regular, no murmurs, lungs clear to auscultation, bilateral, right? EENT, so eyes, ears, nose, and throat. So trachea's midline. Dental findings appears intact. You could talk about all different things, maybe at upper dentures. Again, you don't have to fill these things out, but they won't show up. But notice how every single thing I click over here pops up over here. So it's nice and warm, less than 3 seconds, normal, abdomen soft, present in all quadrants. Fontanelles is going to be for pediatrics. Sure, they're cooperative, interactive, all those fun things. Lines, drains, tubes, devices. In other words, what do they have in? Do they already have an A line in? Lines in situ. In situ means they are already in place. So this would be your opportunity to say, hey, they already got an art line in. Or you can say they definitely don't have an art line in, or no lines in situ, right? So more than likely they have at least one IV. Those are not usually, these are meant for obviously other type more invasive things. And you can write whatever kind of comment you want. Notice that it does, just like everything else in life, you see no neurological exam here. No alert and orientated ×3, moves all extremities, equal bilateral. So for me, that's a big deal. I put those in the comments section. So now we've done the review of systems, we've done the physical exam, and now we need to choose our anesthetic plan. So we're going to say this is an ASA 2 patient. So this is something, again, something that's red. There are general anesthetic. Team communication, like if we're thinking like, hey, I'm worried about something or whatever, you could just put it's going to be an oral endotracheal tube. No invasive monitors for this. We're planning on an intravenous. Again, this is the plan, right? Post-operative opioids intended, yes, it's going to hurt. Ventilation intended, no. Planned trial extubation, sure. Planned disposition, they're going home today. Discuss plan with, if you were the one, maybe you talk to the attending, fellow CRNA, whatever it be. Who was there when you talked to them? Patient was there and their father was there. You can always write anything else that you want in that particular area. Let's pull over here. This is just telling you a consent kind of, hey, I talked to him, I discussed the risk, and then we're essentially done with the note. All these things, these physical exam, anesthetic plan, and review of systems have all been done, and it has now pre-populated this note. Now, this note includes all the information's pulled plus all the stuff that you've clicked, and you still, if you wanted to, well, let's say there wasn't something in area, you could come to the bottom here and you could type whatever you want. And you want to write something else or write anything else, and then you're going to say, hey, sign the note. When it does that, it will complete the note. Now we have a whole preoperative note. So if you want to go through and look through what you wrote, type whatever you want, right? And so you can also edit these notes, right? So you can go through here and you can addend, which means you can add to the note. It will timestamp it, saying that, hey, you altered it at this time and you changed something, and it will keep track of those changes. So if you forgot to do something and you signed it, you go back in here and it brings you right back to where you were. There's your note. Here's all your things. And then you re-sign it when you're done, and it brings you back to pre-procedure. So we've gone through all of these things in the pre-procedure, and now we hit review and sign. Anesthesiologists are allowed to say ready for procedure. You're not allowed to. You can say mark as reviewed twice in the same minute. Sure. It's going to keep on doing that. And so essentially you are now done with the preoperative evaluation. We are now going to go to intra-procedure, because this is what you do, right? You'd fill out your pre-procedure. You'd come to the OR, you'd open that computer, and what you would see is this fantastic little thing. Kind of looks like an anesthesia record. So again, notice there's a top ribbon with the patient's name. It shows all of their information. You have a ribbon over here on the right that has all kinds of things that are pulling from your preoperative note and just different checklists and stuff like that. Again, it's just extra stuff. Notice if I click this here, that goes away. We're making this a little bit better. You see a ribbon of buttons. Usually these are all touch screens, ribbon of buttons here, and you'll notice. So you have a section atop that shows your airway gases. So this is going to look a lot like the anesthesia record we were kind of working on. Look, you've already got medications that are pre-filled in. So notice that this section right here is all together. So all the medications, the output, and the input and the fluids are all going to be in this section here, as well as an anesthetic. Notice that for each one of these sections, you can hide each section, make them real small, and you can expand each section. You can also edit what parts actually go up there, so you can choose which medications, but we're going to show you how the medications work. You can also make it graphical versus just numerical. That's what these mean. So it can put our little symbols that are up here, or we can just physically just look at them in number format if you really want to. There's also an events tab that shows right here, followed by the ventilator. So it's hooking up to the monitor so that it can read these things in the ventilator. For example, my stuff, instead of using the regular, I get all the big cardiac stuff. So I got all this fun stuff, and we can do neuro stuff, including EEGs and cerebral oximeters. And so notice at the bottom, it not only is doing that, but shows what the vent mode is, things like FiO2, SpO2, end-tidal CO2, anything that's being essentially an anesthesia monitoring is going under this section. Now, to get started, and you'll also notice that there's buttons all over here. As we kind of go through these buttons, as we kind of go through this, you'll kind of understand all the different things here. It also gives you plenty of warnings. So it says, hey, this patient has said, this patient has, according to the computer, has met a greater than 50% chance of suffering post-op nausea and vomiting. That's great. So you'll see a lot of the different alarms or reminders. So one of the first things we have to do before we even scan the patient in is we have to choose a macro. And so we're going to choose general endotracheal adult. And what that means, it says, hey, I'm going to pre-fill these medications on the medication side. I'm going to give you these reminders once you do different things and ask you about different lines and stuff like that. And so what it is essentially giving you, so here, we'll remove the macro. So accept. And so notice now there's no medications. It took all those away. So we're going to put the macro back on. We'll do general endotracheal. It's got mine up there, my bypass ones. All right. Now, once we've done that, we've walked in the room and we can now start anesthesia, which means we're starting our billing clock. Now, once we do that, it has started the macro. These are events that are right here. Okay. Notice that I now have an event that says, hey, anesthesia starts, and it puts a little symbol up there. The first thing I want to do is I want to scan the patient in. So I'm going to click Start Data Collection. You're going to say, yep, file. It'll bring up the patient's picture. It'll show all this information. You are going to take their scanner and you are going to scan the QR code, the square one, not the long one. You're going to scan the QR one. And in this particular case, we don't have one, so I'm going to actually override. So I'm going to say the barcode, or I'm going to say the scanner is broken, which you can do. Just make sure this stuff matches. And I'm going to say override. Okay. Now, it is now connected to my device. The way I can confirm that is I click device. It's not going to click to one because I have no devices. If I'm on anesthesia machine B and monitor B, those would show up there at the minute that I scan the patient. Once I've scanned the patient, I am now connected, and it will start pulling all of these blood pressures and things that the monitor is doing. Monitor and ventilator at that point. It starts picking up my flows and it takes care. We're going to enter stuff in. Notice that once, because of the macro, it has put a bunch of things, a bunch of reminders here. Okay, so we're hooked up to the monitor. Now we can do what we normally do: hook them up to our auction, hook them up to the monitor, and even if you forget to do it, you can do it at this point in time, or you can do it later on, long as you remember the time. You can put anything you want in Epic at any time to make sure it's in the right spot. So let's say while we're kind of waiting, just to kind of show you, we can directly input. We don't have to wait for the machine. Notice that it pulls up the events. So I'm going to say I put the auction on 10 liters per minute, right? Let's say I've given them Versed when we came in the room. And so this is the medication. So it has all the pre ones that here, but if you click add medication, you get all these tabs. So here's all the different medications you can click. Okay, so they're all different kinds. But this one already has midazolam pulled, so I'm going to go ahead and hit it. I'm going to choose my time first. All right, we got to choose a time. Oops, we're in 1600 because it's now. So let's say I gave it when I came in the room, and I gave 2 milligrams, right? And you don't have to click given over. I gave it fast. I don't have to worry about it. There's nothing else that needs to be concerned about. All I have to do is hit close, or I can go to a different medication, which I'm not going to. I hit close, and it is now, let's see. Oh, I need to specify an authorizing provider. Let's see. Let's do, let's change that. Usually MDs don't have to do a just type in a. It doesn't make any difference, to be honest with you. There we go. There we go. Notice that it put 2 milligrams at 1622. It came in the room at 1622. I gave it at 1622. Okay, I'll put my fluids in later, but let's say now it's been my 5 minutes and it's time for induction, right? All I have to do is click induction. It'll ask me to put induction meds, but guess what? I'm busy taking care of the patients, right? And so induction's happened, and let's say I went ahead and intubated the patient. These are all going to be real close to each other, okay? And then I've intubated the patient, and now I can kind of calm down, and I've flipped my vent on, I've turned my gas on, I've turned my flows down, and I'm ready to finish charting. So a lot of these things will pull up on their own. Some of them do not, depends on the advancement of their machine. So for example, if it wasn't, I'm going to say that they were breathing spontaneously. I did manual mask ventilation, and then I turned them on volume control here. Notice that from here on out, it's going to say VCV until something changes. When we came in the room, weren't they normal sinus, right? Let's say that they had 0 out of 4 twitches when we intubated because we gave something. And again, you don't have to fill out what the bed tilt was unless you specifically did. Again, it's pulling a majority. Notice kind of what it does right there. It's put all that information in. It would be pulling your vitals at this point in time. And then you'd have to go back and fill in your medications. Notice it says, hey, don't forget to do induction meds because you induced somebody, right? So we can go ahead and add, for example, fentanyl. Let's say we gave it early. We gave 100 mics. Let's say here we gave our, oh, we gotta keep doing that stupid thing, don't we? STCL, just why? Oh, I know why it is. Here's what we're gonna do. I'm going to put responsible provider in. Me. Okay, that's why. Maybe it'll go away now. All right, so if we click meds, it brings us to our medications. We want to click propofol, and we're going to say we gave propofol 100 milligrams on induction, which shows right here, right? And then also, don't forget we gave some lidocaine too, didn't we? Which lidocaine's not in there. Perfect time to add it. It's usually going to probably be under CV or intra. There it is. So it comes in multiple types. Let's say we used the 2% syringe. How many milligrams did we give? 60. We need to choose a time. Time's right. 60. And let's say we gave, notice that you don't have to click confirm. Once you put it in, it's put it in. We've given rocuronium. Let's say we gave 80 milligrams, right? And we click that. We could close. Notice how it puts it all up there. Now let's say that that 80 milligrams is wrong, right? What could we do? We could change the number. So let's say we actually gave 60. Let's say we needed to change the time. That was the wrong time. It's actually 16:25. Let's say I didn't want to give that drug at all. Like that was, I totally want to get rid of it. I want to cancel the administration. Continue. Now it pulls it off. We'll put it back in. Let's say 65. Give it. Okay. And so there's lots of different ways that you can do your medications. What about fluids? Aren't we giving fluids? Absolutely. Go back to meds. Not showing any fluids there. Active is if there's already stuff hooked up to them. So usually if they have fluids already running because of an order, it's sitting right there, but we don't have that. So we're going to click fluids, LR, and you don't have to put, we're going to start back here when we came in the room, and we're going to say new bag, and we're going to say mils because we're not using a pump, right? So all this is doing is drawing a line. You'll be able to see it here in just a sec. There it is, showing, hey, we have fluids, they're open. We'll put a volume in at the end, okay? Just so that you can see what the vital signs look like, or if you had to manually enter them in. So let's say the blood pressure was 120/80. Let's say the heart rate was 68, right? And I'm not going to worry about these other ones. Let's say that normally we'd be taking them every minute when they were taking every minute. So let's say that we'll go on the fives. And let's say the blood pressure went to 100/60. Pulse went to 80. And we choose the next 5-minute interval. Notice that it puts a star there. That means that something has been written on that spot. Let's say the blood pressure went back to 130/65, and heart rate's now 88. And so when we close that, it'll show you, you see the different vital signs, and all you have to do is hover over them, and it'll show you when. What haven't we also done? Well, down here, all the existing monitoring, right? So that was part of the stuff we filled out here, but notice down below, right? I did 100% FiO2. Let's say it's still 100 here, right? So we got to put 100 here. It's probably good. I forgot to put them. Let's say our sat at the same time. Sorry, not temp. FiO2 100. SpO2 100. That should be pulling, but we can put a number up there if we wanted to. Let's go back to this one. Same pay, by the way, we had 100% here and 100% here. And then afterwards at 1630, again, you would be pulling temperatures off. Let's say we have to do Celsius. So 38, 7, and 100. Just to give you guys, and then we'll say this is 53, like you guys ventilated. All right. So notice that it shows this information. Hold on just a sec. It's trying to fill it out. Hold on. It's locking up. All right. Also, while we're working, we can choose the positioning. So the patient was supine, legs were supine, arms less than 90 degrees, padded, pressure points checked. We can change it here, and we can copy the previous, in other words, what we just did, and say, hey, we taped the eyes. And then after that too, we can say, hey, neck was midline and neutral, right? And we close there. Notice that when I do something, it takes it off. There is a checklist. The checklist can be done at any time. Antibiotics were administered and documented. Patient not on a beta blocker previously. Anesthesia machine checked. These are all just one-time checklists that are done. You can go back and change them. We're going to say we put an esophageal temperature in. We're using a forced air warmer, and we're not using any of the other stuff. We'll say warm blankets. So these are just checklists to get done. I'm going through my little list here. Antibiotic. Oh yeah, we gave an antibiotic. Usually there's an order, but there are antibiotics here. Let's say we gave 2 grams of Ancef. Choose a time. Let's say we gave it right there and 2 grams, and let's say I gave it over 30 minutes just for the fun of it. Notice what it does to the line, that it will show 2 grams given over 30 minutes. So it's showing you all these different fun things. And you can, again, if something were to happen, like let's say, and we're going to say anesthesia is ready. Let's say that means it's kind of a timing thing to say, hey, anesthesia is ready. Let's say if there's anything else that would be fun to play around with. We've already done induction, intubated. Now we can say, hey, it's time to extubate. And we click a time there. Notice it brings up an extubation note. So there's all these different things that you're going to be taking care of. You could also do the outputs, since you did inputs. Let's say they had a Foley in and you measured a Foley. Let's say you measured some OG stuff, and that will eventually show up on the totals amount of fluids. Again, just like an anesthesia record, you'd be carrying, it would be pulling the vent information. If you weren't able to pull the vent information, look, it's pretty simple, just like we had. So I worry about what their respirations were when they were awake, 16. What about after I put a tube in and I was looking at the ventilator, they were pulling in 700, or they were giving 700, oops, 700. Let's say the respirators were 10. Let's say there was 5 of PEEP that I set. Peak airway pressure is 45. I don't worry about the minute ventilation. I can put a 1 to 2 here if I wanted to, and I click close. And that will chart all those different things as it's going along. Again, this and this should be getting pulled from by your machine and your monitor. This information down here should be pulled from your information or your monitor as well. If it's not, then we need to check to make sure it's connected to a device. This one's not, which is why we've been putting all that stuff in. Now, I've been able to click directly on this screen to get to each section to just add certain things at certain times, but you can certainly do it from off to the actual left. And so when you see the medications on this side, that'll bring you to the meds, just like it would if you were to click directly into the med session. It usually clicks the one that you opened, but you have all of the list of things that are there as well. Okay. When we click blood, that is for administering blood. And so we have to pick which one we're going to do. And then we actually have to scan the bag, and it will actually bring, it'll kind of do the 2-person check for you by scanning. That's more of advanced stuff. We just kind of get you through the basic stuff. Checklist is, again, that one-time checklist that we've already done, but you can do it all over again. Positioning, we've already done because we had a box that said, hey, check the position. Notice that we've already documented things on the positioning. So that means from here on, nothing has changed, right? If something has changed, then you need to click the time and click what you've changed about their positioning, okay? Or you can click all those things. You click assess. It brings up essentially all different kinds of assessments. Normally everything from anesthesia monitoring. Some of the stuff that's down here, with some of the things that are on there. So if you're using, for example, a warming device, say, yeah, we have a warming device on, it's forced air on, and what did you have it set at? Did we check the eyes? Sure. This is if you're doing MAC cases and you were using a different O2 delivery method than the machine itself. You could do train of 4. You can put labs, ACTs. If you listen to the patient, you can put things here, or you're listening to heart sounds. Those can certainly go on there as well. Okay. We go to procedure notes. So anytime you do something to a patient, imagine what would require a note in the ICU. So whatever is in the ICU requires a note. You click on that, and you'll notice everything from a peripheral IV to putting in an airway, so you have to put an airway note in, or putting in an arterial line, so let's click airway. And so you're probably like, oh, we intubated, that's great. You actually have to fill out the entire note. And so you have to figure out, where were they? This is elective. What time did you put it in? Were they difficult? Who put it in? All these different things. Did you pre-oxygenate? What position were they in? And you can write whatever you want for any of these notes. Yep, I know I need to go back and fill all those in. Go back. We're going to do that. We're going to cancel. Discard. Okay. So you would have to, at minimal, if you put an airway in, whether it's an LMA or an endotracheal tube or whatever, that's going to be a note. When you're done putting those in, those will be procedure notes so they know who put them in. We have extubation lines, doesn't necessarily mean lines. These are things like this that are already in place or were placed, but that are need assessments. Usually our procedure notes create the assessment. So if I put in an arterial line and I did it under procedure notes, it creates the assessment for the nurse post-operatively. I don't have to separately put those in there. If they already have lines in and they're documented, they would show up on a list and you can click on them each individually and reassess them at your convenience. Okay. Anytime that you're doing stuff, because if you see how there's the events, so anytime that's occurring, you can always write a quick note. And so you can always say, hey, surgeon, request torlac for patient. You can write whatever note. You could say, if that's what you want to write, like heart rate accelerated, AFib, lasted 6 seconds, no sequela, you can do that. You can also, if you want to, at any point in time, if you're in a hurry, you don't have time to write a note, but you're really important that you want to remember the time, just hit, you should be able to hit mark now. And when you do that, it actually puts a little thing that when you go back, it says, hey, at 16:39, you said do something. And so you can write out that mark now, or you can even change the event and say, that's when we went to one lung ventilation. And it changes it for you. So that when you're in a hurry, you can just hit mark now. So even your induction and all that stuff, you don't want to go through all this, just hit mark now. And you can go back and change any of those marks to whatever you want. All right. So now, vitals and agents. It's going to show you all the things that are up here as far as gases. So let's say we turned some gas on, right? And let's say right here it was 2.1, just so you can show what it looks like there. So notice at the top, it's now added sevoflurane, and it's assumed that it stays there until you change otherwise. So this line is right now. Notice we're still infusing our ANSEF over 30 minutes, so that's showing in the future. And so there are some more other things. You can choose the anesthesia type, which was done in all of the preoperative stuff. You can change modes, but you can also, we go through here, we're going to bring that down. There we go. It's going to be here. We can go to the post-procedure, pre-procedure again, and all that stuff. If we were to finish, we're going to go to the post-procedure. So let's say we've woken the patient up, and if, just to show you real quick on intra-procedure, go to events, and the very last thing that you click, and again, every place is going to do it a little different. The last thing I'm going to do is going to say stop data collection, and we're going to leave the room. Okay, let's say file event. We're now going to go to post-procedure. Again, this looks a lot like the pre, doesn't it? We have all of these tabs to go through. Everything from a handoff to little notes, and we get all the way to this one, and this is the post-evaluation note, which will look like, once it brings it up, doesn't look like the note writer that we did our preoperative one. So now there's a post-operative one. So they went to the PACU, they're awake, their pain is 0, no evidence recall, airway adequate, pain adequate, normal thermic, yes, no nausea and vomiting, acceptable hydration, acceptable respiratory, acceptable, no complications, and we sign. And the note's done. And so they're going to show you essentially, you have, if you think about the phases, you have preoperative, intraoperative, and postoperative. Your providers are going to work with you on how they want the orders. So we click orders here. There's order sets that are pre-made that are usually destined with whatever group that you're working with. There are usually post-op PACU orders. There are general admission, let's say day of surgery. So these are the pre-op orders. So just to give you an idea what they look like. This one's showing you routine. It says, hey, take the vital signs at least once. Notify the provider if the vital signs are out of whack, those different types of things. Those are going to be up to those sites to determine if you're allowed to put those orders in, and they'll have to teach you how those orders actually go. For example, I'm going to open Packy ones just to show you here. There we go. So these are what the Packy orders look like. It says, hey, when they're in phase 1, take the blood pressure, routine vitals, pulse ox phase 1, cardiovascular monitor. If they go to phase 2, this is how you monitor. It says, hey, when you're monitoring them, notify us if they heart rate's greater than 110, heart rate's greater than less than 50, all these different things. Oxygen therapy, what fluids can they have? Do they need a bolus? Should they have their blood sugars checked? What should be their pain meds? So we get to choose all of their pain medications upon admission, what maybe giving them PO stuff. Do they need insulin, benzos, antidotes? Do they need labs done? Do they need a chest x-ray? All these things that can be ordered. And over here on the orders, accept them. And what the thing it'll do, oh, this one will actually go straight to PACU, is it'll determine what phase of care you want the orders to be in. And then so you can put in post-operative orders, and they will be placed in an area where the nurses can release those orders when the patient gets the PACU. They won't start orders right away, otherwise people may start noticing and sending medications to the OR and stuff like that. So that, for the most part, and once you're done, you'll be going all the way through until you get to this last little part right here where it says sign record. And it'll tell you all the things that you missed. So I missed a bunch of stuff here. And then it'll let you sign, and it will close this tab essentially. Okay, so we're gonna close this tab like we signed it. All right. And so notice that it has a few things on there from when we pushed on it. So it shows that when the patient's been extubated, shows what status based off of what these things will tell you right here. So check anesthesia stop. So anesthesia has been stopped. They left the room, in other words. And usually when they go to PACU, they'll change color from yellow. Usually when they're OR, they'll be green. Right now, since they're not connected to an OR system, you won't be able to see those. Okay, so that's just the quickest and most the easiest way. Let's see. Let me change that. There we go. So let's stop sharing there. So that will be the down and dirty for what Epic will look like. Notice that if you have like a paper anesthesia record, all the same elements that are on the record will be on Epic or an electronic version of it. But noticing that there's the preoperative evaluation, there's the intraoperative record, and then there's a postoperative evaluation, helps you kind of mark everything. And just like you would on the paper, there's a way to do it on the electronic chart. Okay. Let's go ahead and take a little bit of a break here, and then I'll take questions. If you ever go through Typhon's main website or whatever, and you can't find Webster, our account number is 7012, so that's pretty much Webster University. You're gonna have to put in if you ever have a problem with it, there are other login types, and you want student data entry login, okay? And so you're going to have to put your password, username and password for. So we're going to put that one in. And when you log in, it should look like this. And so there's a couple of different things. First, if you look off to your right where it says help, there is instructions, which I don't see instructions. It tells you what devices, but I know they have video tutorials that are on there. Yep. So it actually goes through all these different things. The whole thing is, I think, 51 minutes. But modifying accounts or adding a new case is what you want, or editing a case or missing information, stuff. are going to be the things that you're going to be more interested in. So if it doesn't make sense or you want to take a little slower approach, you can definitely go through the video tutorials, and it should have roughly the same information. Um, there are some downloads that we have pre-built in. You could, if you wanted to print out a sheet that looks like the data entry, then you can certainly do this. So this is what the data entry will look like. We'll get to this here in a little bit. And so you can certainly print out this blank case log worksheet, which would be a PDF. It's showing you what things would necessarily be required. It shows you the different anatomical categories. We'll go through that, but it's a way for you to print that if you really want to. You could also do, let's see, I think we have, yeah, I wouldn't say this is probably the normal care plan. I'm going to say that's what it is, which you guys won't be able to see. I'm just going to check it real quick to see what it is. Yeah. That's what it is. So this right here is a blank care plan that you would fill out. It's in Word format. So this is what you're going to do for your care plan. So that's a blank one right there. Go back to the main menu. All right. You can change your password and all those type of things. The other thing that we're going to get to before we get to the log reports is if you see this other activities and reports, okay? So if you look, you can create your own time logs they're customized to you. They're not for the program. They're not for sitting for the NBC, but they could be quite beneficial. And so it keeps track of things that you do. So eventually, like you could keep track of your simulation time if you wanted to. You could keep track of your own sick time. Research time might be important. So when you start research, it would probably be a good idea to kind of keep track of your daily times. And so, like, for example, let's say today you were in research or you were in the lab, and you were in the lab. Let's see, where is it? Research time. There we go. You were in the lab for 5 hours today, right? And you can also write a note saying we performed self uh, uh, self test to check lab skills. Or you could write essentially whatever you wanted, and you can save that. That actually turns out, if you want to, especially when you're on your semester for research or your quarter for research, that's a great thing to kind of turn in and keep logs of. And this is just another way to keep that kind of log. And you can actually print this up, and you can have your person who's deciding your clinical grade actually look up your research time so they can keep track of your hours and things like that. Again, these are not things that are required. These are not things that go towards the NCE. This is literally just for your convenience. And so notice how it added the one that I put in today. It says we did 5 hours. You can keep track of your call time if you really wanted to. Say I did this many hours of call. You could also keep track of your conferences. Now it does take as far as, let's see, post-operative visits, pre-operative visits, conferences, good. So that's for you to kind of keep, and you can do clinical conference logs. You can store external documents to there as well. Most people do not. It shows your portfolio. This is more of a setup thing. It's usually not something that we set up right away. Usually we get to your pictures and do all that stuff when we start sending out your reports to the NCE. If you had any evaluations or surveys that we don't usually use that system for this. Same goes for, we typically don't put in scheduling and stuff like that through Typhon, but usually let's get back. Usually the time logs are going to be probably the most effective. These are again for how many if you went to a clinical conference and you spent 2 hours doing post-conference, and you can declare how many CEUs, although you don't need CEUs. So really, these are all extra. This is just for you to kind of look. Now, um, the case log reports is something that you're going to be pretty interested in. If you click on case log totals here, if you look all here throughout the left, so this is the sheet that we send, essentially, or a version of this sheet is essentially what we send to the NBCRNA for you guys to be able to sit for the national certification exam. Um, it keeps track of how many, like for example, how many total anesthesia cases. It keeps tracks of your total hours, your total clinical hours, how many ASA ones, how many ASA twos, all those different things, and it compares it to what the minimum required. These minimum required that are on here are what the NCE actually ask for, as far as these are the minimum requirements that you need in order to sit for the national certification exam. And so if you see ones that don't have green numbers next to them, it's because they haven't been assessed as an absolute requirement. They can be added to it, but they're not an absolute requirement. Notice that if you don't fulfill the minimum required, then your numbers are essentially red. Um, if you have gone above and beyond those numbers or gone more than the preferred, which is what we kind of set things, but again, to sit for the exam, you need minimum required, then they'll necessarily turn blue. And so you see all these different things. So for example, you need to have exactly 100 class 3 and class 4 cases. They don't require class 1 or class 2. Everyone gets those. They require you to take care of 50 people who are over the age of 65. They require you to take care at minimum 2 to 12-year-olds, at least 25 kids. Notice that they prefer for those less than 2 years, they want you to do at least 10. And for those that are neonates, they don't require. They will expect you to do 30 trauma or emergencies. These are specialty cases, not pediatrics. So you have to do 30 emergency cases. They want you to do 100 ambulatory. You need to take care, or you need to do at least 10 C-sections. You need to do at least 10 labor epidurals, for example. So these are the national requirements. So as you're filling this information out, it is tallying everything up that is on here. Everything from how many central lines. You need to be able to put 5 central lines in. You need to monitor at least 15 of them. So you need to be able to put 25 arterial or art lines in. You need to monitor if you didn't put them in, but you're managing them. You used it during the case. You need at least 25 of those. How many different anesthetics, types of anesthetics, different induction agents, intravenous agents, regional techniques, all that stuff is on this list. So as you're filling this stuff out, when we're doing your evaluations at the end of the quarter, we're kind of keeping an eye on some of these things, especially as we're getting closer towards graduation. Like, for example, the big ones that we'll be watching for will be the intracranial. You need at least 5 cranes in intracranial procedures. Those are sometimes the hardest to get. And so we watch those numbers so that if you're at a site that those are the only things that you need, but you're not at that site, we're going to try to work it around so that we can get you an opportunity so that you can get your requirements in so that you can sit for the exam. Notice how you have to have a total number of cases. Usually, say they may not all be updated quite, but these are going to be the case log totals. So that you're going to have vested interest in wanting to see that. You can look at all the fun data stuff. So you can look at just your totals, not with the requirements that are on there. So it looks at all those different things right there and keeps your numbers, but it'll still put all the numbers up there. Again, this is just a more detailed list showing a bunch of stuff on there. And again, it's just your totals. And this is just to bulk export. That's going to be a range, which you're not going to require. So most of the meat and potato stuff that you're going to be doing is going to be case log management. Notice you can enter a new case. You can view or edit a previous case, and then it will also tell you, hey, you're missing information from some of your cases, and it can tell you where you're missing that information. We're going to start off by just clicking the Add New Case, and let's say it was today. So I'll do one of my cases that I did today, so we can add a whole bunch of fun stuff to them. So we're going to say we need to click on the one, or you can say, yep, today is the patient returning on the same day, and most likely it will be no. Patient for the second, third time, I've done four. But we're going to say no, and we're going to say save data. And what that does is now that has created a case. So this is case number 1 on 3/1/21. Tells you who you are, right? And if you don't want this to case, like let's say you were there for like 2 seconds, but you put an IV in, right? You want to count the IV, but you really didn't do the whole case, then maybe it's not a total anesthesia case. So we say can't count this case towards, but you may also count it for like an IV. Usually for things that aren't specific, like let's say you put in 4 IVs in pre-op and you didn't, you can sprinkle those into just about any case that you really want to, and it's okay. It's okay that yes, you didn't put an IV on that particular patient, but if you did 4 extra IVs that day, sprinkle them in so that you can get your counts. But because you have to put in 100 IVs throughout your time here. So we're going to go through this field by field. Notice that if you see the diamond, that it is a required type of thing. Let's pick up, let's see what kind of case. We'll do, let's say, well, this will be fun. We did a thoraco-abdominal AAA today, which is a lot of stuff. All right, so we get to click a lot of stuff. We can say that we did it to Paul. So you're going to have to choose which site that you're at. Okay. Again, it's not going to say you're going to be filling out a lot of things that may not necessarily count towards your NCE totals, but they're things that are required from us that we keep track of. So let's say this was a male patient. They were already inpatient. So if I say this patient today was actually 39 years old. Physician code, you leave these two alone, 2 and 1, and then you need to choose their ASA. So this was an ASA, we're going to say this maybe, well, I won't say 5, we'll say it's a 4. Was it a trauma or emergency? No, they were actually in a lateral position. So they were lateral, start off supine, but for the majority of the patient, they were lateral. Notice that you have all these other different options that you can choose from. So this is essentially just information. Usually you kind of move over here and say what kind of surgery did we do? It's not really asking what surgery, it's asking what region or part of the body did you work on. And so we did a intrathoracic heart, and we did it with bypass. We could say it's a closed heart procedure. We could say heart without, heart with. We say open heart with bypass. And oh, here we got thoracoabdominal. We don't even need that, right? So what we're going to say is intrathoracic, oops, and it's going to be a thoracoabdominal. Okay. It wasn't obstetric. It wasn't anything else. Thoracoabdominal is both the thorax, all that fun stuff. We go to the anesthesia type. It was general anesthesia. More than likely, it's a semi-closed system. We did an intravenous induction for sure. You don't really get to count mass management for doing mass ventilation before putting an endotracheal tube in, from what I understand. We did tracheal intubation oral, and we did it asleep oral. We did not do, we did emergence. Technically we didn't, but we finished the procedure. We had no other regional techniques. However, what we could say is this patient, actually, no, we can't. We did a lumbar drain, but that doesn't count on these type of things. Technically, it would be counting as a spinal technique, but we could say regional other. No, we're not going to say that. And we didn't do a MAC, we didn't do deep sedation. So these are things that intravenous induction, remember that's a count. General anesthesia, that's one. How many tracheal intubations? So some of these are actually pretty important. Now, it'll say IV induction, and it's important that you did an IV induction. It doesn't matter how many propofols and things that you used. However, we're going to go ahead and click. Inhalation, we used isoflurane. Did we use muscle relaxants? Sure, we did. We used rocuronium. Any IV agents, opioids, we used fentanyl. Any other IV agents, and there's a bunch of them. So we used midazolam. We used, we'll say other, because we used a bunch of drugs. Okay. Um, Notice that if we go back over here, did you put an arterial line in? Yeah, we put in one. Did we monitor it? Yes, we did. Did we place a CV catheter? Yep. Did we monitor it? Yep. Did we put in a pit or a swan? Yes, we did. Let's see. Did we do fiber optic airway assessment? Yes, we did, because we had a double lumen tube in. We'll talk other anesthesia management and see if there's any other types of things. Nope. Let's see. And ultrasound regional, sure, we did that. Or we didn't do that. We did vascular, yeah, 2. Intravenous catheter placements, no. Advanced non-invasive hemodynamic monitoring, no. We did do mechanical ventilation. Other procedures, actually, we did do that, and we kind of did that. So you'll notice that there's really not much to it. That's pretty much it, other than putting your times in. So you're going to put your anesthesia start, you're going to put your anesthesia finish. So we're going to say 0730, and we're going to say 1400. Okay. It's going to say questions about this case. Again, delays and indicators are not things that go on your NCE. It's something that sometimes you may want to put on there, so in case you need to remember something about that. So maybe they had some kind of airway injury, or you kind of like nipped the lip a little bit and you got to cut into it, or maybe there's a delay, and all these other different things that you can kind of go through. So unexpected, like ocular injury, because they had, maybe they had a low heart rate or sustained heart rate that wasn't expected, or MI, all these fun different things. Return to the OR, unplanned ventilation. You can go through. These are not going to, like, they're not there to ding you. They are literally just to kind of gain more information, and they're not used against you or anything like that. That's literally just data. And so we can't tell who this, I mean, we can kind of look at an OR schedule and kind of figure it out if we had to, but we're not going to. This is supposed to be data that is, excuse me, literally just trying to get your counts up, to figure out what your counts are. So if we finish this case, we can, and you can write whatever note. Just don't put anything that would violate HIPAA, but you can put anything that you want or any kind of notes in there, and then you're going to click save. You must also choose open heart or closed heart under intrathoracic. Okay, so we did closed heart, because technically we didn't open anything up. So we're going to say closed heart and heart with bypass. So we used bypass. There we go. Save data. You also need pick or non-pick when doing. So that would be a non-pick placement. Okay. There we go. Oh, we guess we have to put a number. Oh, that's simulated. So just put 1. Okay, so now let's try. Great. Now, if for some reason you had missing information, you could go to missing information, and it will show you all the cases that you had missing information on. And it will tell you, say, hey, look for that. And see, I forgot to put the gender, admit type, years. So I didn't even finish this one. I didn't put the times, didn't put any medications. I didn't fill it out. What if I wanted to delete this? Well, you could delete this case log down here. So we can click that. It says, yes, delete the record. It's no longer there. Or view or edit case logs. And I could go through and, so if we did this around the same time last year, I could go and look at this case at any point in time. I can go and edit it So this is showing all the things that I checked off. I can go edit it, just like I did, and save the data. Or I can go in whichever case that I wanted to, and I could choose edit, and then I can go down to the bottom and say delete that case. So you can go in and practice adding cases, like add new long. So don't be afraid that you have to get it right the first. You can always edit them, and if you want to, you can start over and you can delete them if you wanted to. It will automatically update what your case log totals are for that period of time. Um, I would recommend, it's easy when you're doing this 1 day a week to be able to get them in at the end of the day, do them first thing, but do not. This is one of the hardest things. I had the hardest, all of us had the hardest thing. We were one of the first few classes that got to use this system, because before you actually had to fill out an Excel spreadsheet, like you had to like old fashioned like figure it out. The hardest thing was remembering to do this, or not being lazy, or putting things off, because one, your grades are going to be based off of making sure you're putting your case logs in. So if you don't get your case logs in, and then Dr. Koopman looks at your things and sees no case logged whatsoever. Same with getting your evaluations filled out. They come in, there are not enough evaluations for the number of days that you worked, then that's going to help determine your clinical grade. So your clinical grade will suffer if this stuff is not in the computer and you're not filling out your daily evals from your preceptor. So make sure that it's easy when it's 1 day a week. When you start doing 3 days a week and you're doing 4 days a week, fill it out every single day you're in clinical. I know you're tired. I know you're overworked. I know you don't want to do it. Sit down. It won't take you that long. I think it comes up pretty well on your phone too. I don't think they have an app. I'm not sure actually. It's been so long since I've actually had to do it. Um, you can, if you want to, that bulk export. I'm just seeing the little reminder here. If you want to, you can always bulk export stuff every now and then, just to make sure you have stuff saved on your end if you really want to. Or when you want to do the case log, you can take a screenshot of that case log and keep track of all of them. But the bulk export, and just keep it as a file on the standby, and just keep all those backups, and that way you can keep an idea of what's actually going on. So there might be a few questions about these. So go ahead and start firing them away.
So you said, so whenever you do enter a case or whatever, depending on whatever you check, it is going to flow automatically into the case log totals.
Yep, absolutely. Mm-hmm.
Cool.
So you don't have to do that. That is something that will, when you delete stuff, or when you add stuff, or when you edit stuff, it automatically updates the case log, or keep track of your whatever case log that you're looking at. So you put in 4 cases, you should see when you finish those 4 cases that your number of cases increased by 4 on the case log. So if I have like here, let's see what my case log is. So I have 9 cases. So if I go back and add another one, add new case today, sure. Yeah, I'll just quickly put one in. Patient 6721, trauma emergency prone, extremities, upper. I'm just clicking stuff to be clicking stuff here. Closed. Intravenous induction. Emergence from anesthesia, and let's put some drug, no medication, somehow, miraculously, no medications. And remember, we got to fill out all the arrows, 1400 to 1425. So that's fine, and we save. So now I should be able to go here, and I've got 10. So see how it automatically brings that up. It changes all the ASAs or classes, and then I did another 67-year-old, so that went up by 1. So it will automatically do that. You can export this if you want, or you can export the raw data. off the bulk if you want, just to keep a track of your numbers. But you can always come back and look at this stuff as well. Any other questions?
I have a question, Nick. You said the preceptor evals, does that go on here or is that different?
Nope. So those will, let's see if I can, actually, since we're on here, let's go to Webster. Let's go into World Classroom. I think you should have access to those. So let's go down to, where is it? Resources. And let's see if they put it on here. They should almost be put on here. So let's look at forms. Daily clinical evaluations. Let's say clinical experience 1. All right. All right. So this is what the daily clinical eval should look like. So if you, you need to print a bunch of these out or have them. And so at the end of the day, whatever provider that you're with, or if you've been working with one a longer part of the day, is you're going to need to present this to them, and they know what this is going to be. But this is your daily evaluation form. So the preceptor will fill out these different sections. Um, so the E, the M, and the N. N is needs improvement. M is meets the requirement, and E excels. And just because you meet the expectations doesn't mean that your grade is lower. It doesn't mean that you have to get all E's in order to have an A in your clinical evaluation. Um, there's a lot of it that goes into it, from percentage that you complete of these, and some other things, and some of the comments and things. And so the provider will fill all of this information out, and then they can also talk about any of the strengths or weakness in regards to these types of things. Same could be said for like knowledge, whether they supervised or instructed you on certain things. And so it goes all the way through technical skills, all those different things. And critical self-appraisal. So this is a section that you fill out, talking about what you think about how the day went and things like that. And so provider fills out all this fun stuff. You fill out this bottom part. They can fill out the back of the sheet if they want to. And they'll have their instructor name and all that. Oh, here it is: exceeds, meets, and needs improvement. Indicate for each item. And written comment required for each section. So for some reason, they want the provider to fill out each one of these like they are going to, which I doubt they will, but most of them will just put good job, good job, good job. But you also put your cases that you performed on here, what facility and the date. So these cases that you perform should match up with what you put into Typhon. So these are your clinical daily evals. And if you notice too, they really don't change from quarter to quarter. It should actually be roughly the same other than the title at the top. And yeah, so these are typical, even by here, I think they're roughly the same. There you go. Roughly the same. So these are, so when you go to clinical, to warrant your grade, you're going to have to make sure you fill out your Typhon to tell us what cases you did. You're going to have to get on a daily basis. I don't know how often Dr. Stoltz wants the case studies and in what percentage or what number, but for every day you need at least one clinical eval. That's what these things are. You need at least one clinical eval per day that you're in clinical. Okay. And so someone needs to fill these out. Failure to have a clinical evaluation for the day is more than likely a deduction from your clinical grade for not having it. So you need to have one every day. So you're going to have to make sure you have one of these with you. The little hand forms that I gave you that were like cheat sheets as far as what's right is just for you to help fill out your help you fill out your case care plans, which I don't think are on here, but they were on Typhon. That's not it. Program schedules. No, okay. So they may not be underneath here. Yeah. So you'll have to have daily eval. You're going to have to eventually turn in a care plan or however many she wants for that week. And so you should have one care plan, one daily eval, and that should be about putting your cases in Typhon. And those are going to be currently your requirements. There may be more, but these are the requirements for a clinical day. Does that make sense?
Yeah, thank you.
Any other questions?
Yeah, Nick, will the care plan be on just one patient or all the patients that we had?
That's up to Dr. Stoltz.
Okay.
So whether she requires one per day or I imagine it's going to be one per day. I doubt it would be one for every patient because what if you did 20 patients before noon and someone did one case? So probably don't want that, right? So more than likely one per clinical day, at least for this first quarter. I don't know what she'll require in the summer because she will be in charge of your clinical course in the summer as well. Any other questions?